everybody. We are turning up the air conditioning. I know some of you are cold, so I apologize. And we're also getting some more coffee and tea, so if you're really cold, maybe in a few minutes you might want to wander back out there and get some. Did everybody get scanned into this session? Okay, so we're going to start our afternoon session off. We're going to do another Mentimeter. So those of you who have not done the Mentimeter, please go in and log in like you did before and use your code. And we're looking to have you answer this question. Thinking about what you have just heard, if you were a patient with sickle cell disease, would you try hydroxyurea? Think back to the interview we did with Dr. Smith. And as you're addressing this, I would just like to reintroduce Dr. Lopato, who is going to provide some information to us on hydroxyurea and some of the other therapies that are going on out there for you to get updated on. So Dr. Lopato?
Thank you. So do I leave this?
Do you want to make any comment?
Yeah, no, I don't need any comments. Okay. Well, I guess I will say, can you go back to it? Yeah. I guess I will, it's nice to see definitely not, at least not being high up there. But obviously we do have a lot of individuals who say definitely not. And even after giving them robust education, still say definitely not. All right. Yeah. All right, so there are a lot of slides here, so I'm going to run through a lot of them, really highlighting what I really want you guys to get from hydroxyurea. So obviously, what is it? How does it work? Why don't patients take it? What's the evidence supporting hydroxyurea, supporting the concerns? When do we prescribe it? And what can be done to improve its use? And I'm probably going to be leaning on Dr. Smith to weigh in on that one. Yeah. All right, so what is hydroxyurea and how does it work? Let me make sure I didn't miss anything. Okay. So this is just kind of give an overview of what we've already talked about, what sickle cell disease is. Abnormal hemoglobin leading to abnormal red cells. The red cells then get destroyed by the body because they're abnormally shaped. Patients develop anemia, don't have enough blood oxygen to their tissues. They develop ischemia, they develop pain. Now, as I talked about, kind of went over hemoglobin F and what it is and why we once had it, and why hemoglobin F is protective in sickle cell disease. Hemoglobin F, to reiterate, when it loses its oxygen, it stays put in those 4-chair conformation, does not bind up into a long polymer. So hemoglobin F functions the way my hemoglobin does today. Hydroxyurea increases hemoglobin F. And the discovery that was made by that pediatrician in New York that hemoglobin F is protective then set into motion this search for a drug that will increase hemoglobin F. And so that's what hydroxyurea does. What it also does, it decreases white cells. And that becomes also important because remember I said that sickle cell disease isn't simply a plumbing issue, but it is an inflammation issue. where the red cells and the white cells stick together and stick to the inner lining of the wall. And so because hydroxyurea decreases the white cells, that is thought to also be a role in how it works positively for sickle cell disease. Not going to go into any detail or depth about how it does that, but it really works at the level of the bone marrow. And so it is telling the body to produce something that the body has long stopped producing, but still has the memory of how to do it. And because it works at the level of the bone marrow, it decreases the white cells as well, which are formed from the bone marrow. That is a good and bad thing, and we're going to get to that. So it increases hemoglobin F, like I mentioned. MCV. So MCV is a measurement of, I like to say it's a measurement of how kind of round and plump the red cells are. When you get a lab called a CBC, which we've all gotten it, and individuals with sickle cell disease have gotten more than I will ever have if I live 10 times. An MCV is one of the standard things that comes with your hemoglobin. And so if I had, let's say, iron deficiency anemia, my MCV would be small. Kind of think of the red cells kind of shrinking up, smaller. And so hydroxyurea increases the MCV. This is very helpful for us because it is one way that we are able to see if patients are taking the medication and if they're taking it at the right dose and taking it consistently, because those two things are very important. In the studies, it showed that when taken at the right dose and taken consistently, it significantly decreased pain crisis. And it decreased the need for blood transfusion. So because it increased the hemoglobin F population in this room, in this red cell, the red cell is less likely to be deformed. And if it's less likely to be deformed, it's less likely to be destroyed by the body. And if your red cells are less likely to be destroyed by the body, then your hemoglobin is less likely to go down. You're less likely to become anemic. And so that's one reason why in the studies, the patients needed less blood transfusions. And also, they used the hospital less because their pain crisis was less. And so it really, you could see the impact from the lab value, and you could see the impact from what the patient is saying, and you could see the impact on what the patient is actually doing, regardless of whether or not they say. It's making this big difference, but then you look at the cohort of people that were getting hydroxyurea, they truly were going to the hospital less. And that is a wonderful thing that a drug can show, which is see how it changes your cells, see how it changes what you tell me, and see how it changes what you actually do regardless of what you tell me or regardless of what your labs show. And this just kind of goes into detail more of, so the blood markers, hemoglobin went up, the percent of hemoglobin F went up, the percent of the MCV went up, pain crisis went down, hospitalization went down, need for blood transfusions went down, incidence of acute chest syndrome. This is where patients will have essentially a sickle cell crisis in their chest. The way it manifests is presenting to the hospital, being short of breath, probably and most times needing oxygen. On a chest x-ray, there's evidence of what's called an infiltrate, which kind of looks like pneumonia. And so that is a very serious complication of sickle cell disease. And to see that a drug actually decreased a serious and life-threatening complication of sickle cell disease was great. And then overall, it decreased mortality. There are some things that it did not look at least in the initial studies, but later on, I think in particular, and probably Dr. Sister will talk about it regarding to strokes. But is this a perfect drug? No. There are other things that patients experience: priapism, leg ulcers, infection from sepsis, that we can't sit here and say it changes all of that. And obviously, you didn't see avascular necrosis there at all. So in the studies that, Dr. Smith, you were a part of them, right? Yeah. You can see the improvement in mortality over many-year period. So here you have patients on the drug, and there really is a significant decrease in mortality. Dr. Smith, can you comment on this slide? This is where they talk about the strokes.
I sort of hesitate to show the slide.
Yeah. I sort of hesitate to talk about it.
This is what I would consider a good news, bad news study. The good news is if you rigidly watch whether children take hydroxyurea like they should, and they take it like they should, you don't have to transfuse them after a stroke. You can just give them hydroxyurea. And that just sounds wonderful, right? But the bad news is now you've lost your chance of monitoring whether or not they're doing what they need to do to prevent the stroke. Because transfusions is something you can monitor. You can see it. You can see when they get a transfusion done. You can say, okay, they're covered. They got a transfusion. Hydroxyurea, it's you and your parents. And if you go oops and you have a stroke, ooh, not a good thing. But this study was meant to demonstrate that hydroxyurea was powerful enough to be as effective as transfusions for preventing a recurrent stroke.
So hydroxyurea became the first FDA-approved drug for sickle cell disease. There are only two. And I want to point out when, look when it got government approval. This was during Bill Clinton's time. And if you look at the history of sickle cell disease research and understanding of sickle cell disease, the genetics, the protein, what it looked like in the human being, and even the potential treatment, the fact that hemoglobin F was potentially a treatment, was all known by the 70s. And it took this long to get one FDA-approved drug. So this just kind of talks more about the approval history. So hydroxyurea is effective in the treatment of sickle cell disease for adults and children. And I like to tell my patients that hydroxyurea is a disease-modifying treatment because pain medication is a treatment. A blood transfusion can be a treatment. IV fluids is a treatment. An antibiotic is a treatment. All of these are treatments for sickle cell disease. But when you're talking about a chronic condition, short of transplantation, and wonderful gene therapy that Dr. Smith will wow you about. It is a disease that you're going to have from the day you're born until the day you die. And so you have to think about treatment that is going to modify, if it's not going to cure it, modifies the disease. We think about that in any other condition, type 2 diabetes, hypertension. We specifically use the word disease modification in rheumatoid arthritis. You have pain, you have swollen joints. We can give you pain meds, but we also want to give you something that will modify your disease so that it actually changes something about the way your disease functions in your body every single day. Hydroxyurea was the first disease-modifying drug treatment for sickle cell anemia. And that is very important, that it is a disease-modifying treatment. So why don't patients take hydroxyurea? This is just data that speaks for itself. But I'm going to get to the slide. This obviously just tells us that hydroxyurea is underused. It is underused by adults. It is underused by children. Here, why don't patients take hydroxyurea? So, fear or concerns about cancer. This one threw me for a shocker when I was in Minneapolis. And patients were teaching me about hydroxyurea. Because I just put my hand up and said, sure, I'll work in this clinic. Take hydroxyurea. And they were like, this causes cancer. So then I'm having to read up on it. And to learn that, you know what? This drug was used for some kind of cancer. So now you're saying, do I have cancer? There was some concern that it causes cancer. And then just lack of understanding about what hydroxyurea is. And not being able, not having somebody sit down and say, this is how it works. This is why we want you to take it. And also trying to get patients to take a big capsule, take a lot of it for the rest of your life. I have hypertension. I take 3 pills. I sometimes get tired of taking it. They're tiny pills. I don't need water to take them. But imagine being told, take 5 of these capsules every single day. And oh, by the way, you're still going to have all these other complications. That ain't going to go away. Well, we shouldn't be surprised that patients don't want to take it. The need for frequent monitoring. Remember I said that hydroxyurea decreases your white cells. Well, it does. And white cells are there to fight infection. So if we're giving you a drug that decreases your white cells, then we need to make sure that your white cells are not decreased too much, that you're set up for an infection. So we typically will see patients every 2 to 3 months. Maybe we'll let somebody go without getting their labs checked, if we know they're stable. But it takes monitoring to be on it. And then a big one is having providers just not feel comfortable prescribe it. And initially I wasn't comfortable because, you learn that this is a chemotherapy drug that was used for some kind of a cancer. And am I qualified to prescribe it? Well, I would say something that may be very provocative. But if a government gave you a DEA to prescribe oxycodone, then my goodness, you better have some knowledge about how to manage hydroxyurea. Because prescribing pain medications at the doses and the amounts that we prescribe it, you better know what you're doing. And you're more likely to get your patients in trouble, sickle cell disease or not, with a pain medication. And so when I talk to residents and make them change their focus to realize that, yes, you can learn how to prescribe hydroxyurea and prescribe it safely, because we prescribe a whole bunch of other medications with horrendous side effects with a lot less education. So obviously there is no risk of malignancy in people taking hydroxyurea, and that was showed in the studies. This has come up as the newest concern in males, that and this again is where patients educate me. Had a patient say, I don't want to take hydroxyurea. This was here in Virginia, after taking care of sickle cell patients for 4 years. I don't want to take hydroxyurea because I want to be a father and it causes infertility. My answer was, no, it doesn't. And I went home and I was like, yeah, Toko, why don't you read up on this? 2 months later when I saw him again, I said, you know what? You're right. Let me explain to you now, but you're right to be concerned. And my answer of no, it doesn't was not the right answer. Yes?
It seems that there are research studies on rats and mice. Have there been any research studies in humans to show that that's the case?
Dr. Smith, I don't think there have been studies on humans.
Not specifically for the purpose of showing this.
Yes.
So
We just observed over time
Yeah.
whether or not it caused problems in the studies that were done for other purposes.
Yes. So nobody did a study to say, let's figure out if that's what's happening. Yes.
So it's not completely accurate to say that you had to go back to the patient and say that's true.
Well, if people know me, I tend to speak definitively. And so my no was definitive. I mean, it was as definitive as I would have said, no, it doesn't cause cancer. I mean, I was like, no. And I felt like I really, because clearly it was, I mean, I did like a Google News, and it was like, there were blogs. And then there was really concern, and there were research experts talking about this publicly, like, does it decrease the sperm count in males? And there is some very valid, significant concern that it does decrease sperm count in males.
Concern isn't data, right?
Yes, absolutely.
Most truthful thing to say.
Exactly.
You don't know.
Yeah. So after having that complicated conversation with my patient, he actually ended up deciding to take hydroxyurea. And when I think about this conversation as it relates to infertility caused by decreased sperm count. So it isn't that you become infertile because kind of like you took a Lupron agent that got rid of all of your testosterone, or that you were castrated. But infertility in that it affects the function and the number of active sperms. I liken that conversation to the one I have in primary care with patients who are deciding whether they're going to get a PSA blood test for prostate cancer. It's not an easy answer. Some people say yes, some people say no, some people say it's worthless, but then there's always the person that got it and their prostate cancer was discovered and they got a treatment and they're happy. And so this is where having the relationship
Yes.
with the patient
Yes.
and being able to talk about what hydroxyurea does, what are the proven benefits, and being able to weigh them with the possible risks. And you're right, they are possible. It's not definitive. And I think that one of the things that we don't do well with our patients is giving is, we assume that they're simply going to take this drug because they have a horrendous disease that I can't even begin to imagine. So my response is, my goodness, if somebody gave me something that was akin to rat poison, I'm just going to take it if they told me but that's just not how we think as human beings. And I've had many young doctors who say, I can't believe they're not taking hydroxyurea.
Oh, yeah.
If you tell me how horrible the disease is, why aren't they taking it? And I had to get past that issue myself and realize that it's my job to do the educating. And it's my job to talk about it tomorrow and next week and next year, just like we try to motivate anybody to do other things that we know will help their health. Stop smoking, lose weight. We all know these things are going to be helpful, but we don't toss out the person as though they have some issue because they don't follow your lead. They don't do what you say. Yes.
I just want to make a comment with patients not taking the hydroxyurea. So I run our social media at Hopkins on all platforms, and social media has a big voice. So I sometimes have to take off my professional hat, put on my parent white hat to dispel rumors because it runs rampant on social media. Hydroxyurea gives you cancer. Hydroxyurea does this and does that. So I have, what do you suggest when I'm on these platforms? Like, how would you suggest to speak, professionally without not being incorrect? Like, what kind of suggestions when we see things that aren't true, like to dispel things?
Yeah. I guess I try not to ever go on those platforms. But I think that if you are trying to reach patients and you're an advocate, then I think you have to. And the way I try to approach it with my patients, with my patient in the room, one is I try to get my facts in order, which is why I went back to that patient and said, my answer of no, it does not, was incorrect. Because I cannot definitively tell you no. This is now what I have learned. This is what I have researched. With you can't do this on social media, but with my patients, I will oftentimes go out of my way to do a literature search in front of them, so that they see that I am not simply saying I am the expert and you have to just simply listen to me, but I am continuing my medical education on this topic. And being humble about hydroxyurea. I like to tell my patients about the history of sickle cell disease and the gap in treatment. And I like them to understand what it meant for the researchers like Dr. Smith to bring this on board and for the patients who enrolled in that study and what that means. Because then they see the passion that I have. And so when you then tell them, but yes, you know what, this isn't going to fix everything. When you tell them this isn't going to stop your avascular necrosis pain, then they finally realize, oh, you know what you're talking about. Because what oftentimes we say is, take hydroxyurea and your sickle cell pain is going to go away. Or your sickle cell pain is going to get better. And then they're kind of looking at you like, you really do not know sickle cell disease. And if that's the only conversation you have to the patient, they simply won't believe you. Yes?
I'm on a lot of social media websites, a lot of patients out there do have questions, but some doctors are not even, prescribing it or recommending it to their patients.
Yeah, yeah. You know, another way that I like to explain the benefit of taking a disease-modifying drug is that we now have our patients living into their 30s, 40s, and 50s. And if I can give a drug that may not make your today go from 3 being down there to a 9 being close to great. But if I can convince you that taking this drug might mean that a lot of these other complications you might have later on, 10 years, 20 years later, may decrease. That your chance of getting it is going to decrease. That's the conversation that I'm starting to have with my patients. Yes?
I'm talking about a medical profession.
Yeah.
They're not even in agreement that this is a beneficial medication and are not recommending or prescribing it to patients.
I think that the medical community of people who take care of individuals with sickle cell disease are in complete agreement. So I would be shocked to find a sickle cell provider who would sit here and say, no, hydroxyurea is not beneficial. I think there might be disagreement on when to begin taking it, whether it is, you know, you've gone to the hospital and you've had 1 crisis a year, and that's it. That's all you had last year. Should you take it? Or should we wait till you have up to 3? What if, let's say, you don't have a lot of crisis, but you were just told that by your ophthalmologist that you have beginnings of retinopathy? Should you take it? So I think that within the sickle cell provider community, there isn't disagreement on the benefit of hydroxyurea. There may be disagreement on when to begin. In the larger medical community, I don't think I have found a doctor who says, no, hydroxyurea is not beneficial. I think the biggest thing is just lack of knowledge within the medical community. It's lack of knowledge. And unfortunately, when you omit something, oftentimes it is interpreted as, well, that must be bad. And it's really, the problem is that it is being omitted. It is being omitted by the primary care doctors, and sadly, it's being omitted by the hematologists themselves. So this is talks to the concern about hydroxyurea in pregnancy. And so obviously, as Dr. Smith talked about, there were some pregnancies during the study. In India, they actually gave low-dose hydroxyurea to women with sickle cell disease. And right now, there are no birth defects from multiple reports of women being pregnant on hydroxyurea. Are we ever going to get to a point where the FDA is going to change that classification? No. But I think that within growing clinical practice, we are beginning to see this happen more and more, that women who are pregnant remain on hydroxyurea. All right. Okay, so when should hydroxyurea be prescribed? So I think the kind of standard evidence-based answer is 3 or more sickle cell associated moderate to severe pain crisis in a 12-month period. Now, trying for me to figure out what is considered moderate to severe is difficult, because oftentimes that's just not how the patients express their pain. But generally, we think about if you're in front of me and I see that you've been to the emergency room in the past three times in the past year, then I need to start having this conversation about hydroxyurea. Sickle cell associated pain that interferes with life quality and activities of daily living. So that right there, that's a lot of people. People who don't go to the emergency room. And also, let me back up and talk what's a little bit more nuanced with the pain crisis. When I'm trying to figure out how many pain crises a patient has, I think I'm being slick. So I look in the EMR and I look to see all the admissions and look to see all the ED visits, and I say, all right, you had 10 ED visits last year. This year you had 5. You must be doing better. Well, one of Dr. Smith's studies showed that a significant number of patients manage a significant number of their pain crises at home. They never go to the emergency room. That is the last place they want to be caught. So trying to figure out if somebody meets that criteria isn't easy. And you have to dig deeper instead of simply looking at how many times did you go to the emergency room. And then if you simply have chronic pain, or it isn't crisis pain to get you to the emergency room, but it is affecting your daily life. It's affecting what activities you do and how you do them and when you do them. Then you should think about hydroxyurea. If somebody obviously has a history of acute chest syndrome, and then if somebody has really symptomatic anemia, they're significantly anemic, they're at 4, they're at 5, and you see and they report that anemia, not pain, just the anemia itself, the shortness of breath, the degree of fatigue is impacting their life, then that's another reason to consider hydroxyurea. I don't know if Dr. Sisler is going to talk about this.
She's going to mention complications.
Okay. Dr. Smith, so the youngest is 9 months? Yeah.
Started historically patients that are 9 months of age, and we can start talking about it almost at the first or second
Perfect.
visit with patients in clinic now. There are some patients that we've started hydroxyurea that are less than 9 months of age because they're symptomatic. They've had recurrent dactylitis or complications that would warrant, that indicate that they have severe disease at an early age. And so we do start hydroxyurea if it is safe to start at a younger age. But yeah, historically now we are starting SS and S beta 0 patients at 9 months of age.
Yes.
We actually start at 5 months, and the primary reason for that, and we just, I believe our paper is now made public, because what we're trying to do is catch it before the F turns off.
Okay.
Mm-hmm.
And so why wait to
Okay.
see and respond after
Okay.
if we can prevent it earlier on? So when they first come, right around, some come at a month, some come at 3 months, we start talking about it then so that we really give them an opportunity to think about it. We start providing education materials, things that they can read, literature, hopefully connect them to other families. And then when they come back for that 5-month visit, because we won't see them again until the 7th month, we look at starting at that 5 month.
Now that's really interesting that you guys think of it in that way, and really I just hadn't thought of it in that way. But it makes absolute sense, because I just finished telling you that hemoglobin F is protective, and we're going to lose it all. So if we know that, and hydroxyurea raises F, why wouldn't you give it when the F naturally starts to go down? Yeah. Other times to give hydroxyurea, I'll go down to the second part, obviously strokes. Dr. Smith talked about that. One of the areas where, and Dr. Smith, you can chime in, we sometimes will have patients who have had a stroke, you know what I'm going to say. They've had a stroke, maybe they were on exchange transfusion as a child. They got off of it because life happens and they don't want to be attached to a clinic every single month. And then they come in to my clinic and I get this history for years. And I'm like, you've had what, a stroke? And they're like, oh no, I'm not doing exchange transfusion again. Do I put them on hydroxyurea? And yeah, we don't know. I have suggested to a patient of mine, and he's on it just for that reason. But is the evidence there? We don't know. Chronic kidney disease. There is some evidence that, so the kidneys will begin to spill protein in the urine. The kidneys are supposed to keep the protein that's in the blood and not spill it into the urine. And you can do a very simple urine test to figure out if there is protein spilling in the urine. And that can be a sign of early kidney damage. That's one of the ways we diagnose early kidney damage from type 2 diabetes or hypertension. And we see this happening in sickle cell disease. And there is some evidence that given hydroxyurea can keep that process from getting worse. So possibly another indication is having chronic kidney disease, where your kidney function is permanently decreased because of the effects of sickle cell disease. Of course, as you can see, weak recommendation, not great evidence. And then going to one, should we be giving hydroxyurea to somebody who has sickle beta plus? So this is the one that I said is very mild, or hemoglobin SC. Well, obviously, people don't read textbooks. Our bodies don't function based on what the textbook wrote. So yes, we have some patients with beta plus that are very sick. But I do struggle with this for somebody who has beta plus or SC and they don't have a lot of sickle cell crisis. So thinking back to the patient that I talked about who has bilateral hip, avascular necrosis in his shoulders, has significant chronic pain. He is not on hydroxyurea. I don't think I have ever truly pushed him on it. And maybe I'm wrong, but I'll tell you my reasoning is because I know that all of the hydroxyurea isn't going to change the degree of pain he's living in. But is it still right that he's not on it? You know, what happens, you know, are there some other benefits that he could get from being on hydroxyurea? Is it gonna, could it protect his kidneys? Could it keep him, decrease his likelihood of having a stroke? Not make it go away, but decrease it. Is there still some benefit? We don't have the studies to show that. But hopefully one day we will. So things that we check for when they're on hydroxyurea, we talked about obviously your CBC, your white count, reticulocyte. So reticulocyte are cells that are kind of immature red blood cells that can divide up and become hemoglobin. And when somebody has a crisis or an infection or bleeding from trauma or just bleeding, the reticulocytes go up because the body is trying to make the red cells. Hydroxyurea suppresses the reticulocytes because it works at the level of the bone marrow. And that's one of the markers that we use, same with the MCV, that's one of the markers that we use to know when the patient is taking it, the right dose regularly, and when it's having that effect. And we know how much suppression of those new red cells we want to achieve. So that's something that we check routinely. I like to check hemoglobin F. I like to check hemoglobin F before I get the patients on hydroxyurea so that I can show them what I said is not just something I read in a book, like actually your hemoglobin F level is changing. Are we able to correlate that with clinical manifestations? No. We don't have a marker where we say, give your hydroxyurea, and the goal is to get your hemoglobin F up to 12% or 15. We don't have that. But it is something that I like to use to show that it is actually doing something in the body. I haven't had much issues with kidney function or liver function being affected by hydroxyurea. Dr. Smith, do you get a pregnancy test in a woman before you start hydroxyurea? I don't. But obviously, we educate them that if they become pregnant, they should stop it. I now have a very nuanced, detailed conversation about women still being on hydroxyurea when they're pregnant. But my recommendation is still to stop it when they become pregnant.
We plan.
Yes.
We have conversations with people, families, about family planning. When do you want to have a baby? If you don't want to have your baby exposed to hydroxyurea, would you like to come off of it and have a baby?
Yeah. This slide just shows that it's dose dependent. And so many times the other mistake that we make is we get somebody on 1 capsule a day because that's what they were taking when they were 12. And here they are, they're 35, and they're taking that 1 capsule a day. Well, it should have been increased because it's based on your weight. Dr. Smith, what can be done to improve? Tell me if I'm wrong. Insurance at this point isn't an issue.
It still is an issue.
It still is? Okay.
The reason why it's an issue is people, while they might not get a prior authorization, people on hydroxyurea are questioned as to why they're on it by insurance companies who are ignorant of sickle cell disease.
Okay.
They look at the chart and they say, you don't have cancer.
Yeah.
Well, why are you on this drug? And by the way, you're taking a whole lot of it.
Yeah.
You're supposed to only take it once every 3 days. Well, that's how you take it if you have cancer. So, yeah, it's still an issue.
Okay. Okay, this goes into, and then, okay, so improved coverage for sickle cell disease. Fortunately, I haven't had to do a prior authorization for hydroxyurea. I haven't had patients tell me that their insurance won't pay for it, so it might be a barrier or a hump that they largely can manage without my intervention. Yeah, so one is really getting providers to be aware of it and to prescribe it. The last one, which is very important, is that transition from peds to adult. I will oftentimes, especially if they're all in the same institution, I'll pull up their MCV that plumpness of their red cells. And if I can do it right, I can show what it was when they were still coming to the clinics with their mother and dad, and what it is now that they're coming by themselves, now that they're transitioned. And I'll say, I know you were taking hydroxyurea then. I know you're not taking it now. And I think a big part is this transition. And there are obviously a lot of barriers, a lot of hardship that occurs in the transition, hardship that are inherent to just transitioning to adulthood, but then transitioning with a chronic disease. But then there are hardships that the healthcare system puts in place, which is essentially pulling the rug up from under them. Dr. Smith, do you want to talk?
We're working on that. This is our quest in the state of Virginia, and I guess North Carolina might be already ahead of us. Maybe people in North Carolina want to talk about this. What are y'all doing?
North Carolina.
One of the things we do the echo clinics where we send out invitations to the providers throughout the, southeastern parts of the country, not only in North Carolina, but other states as well, and we provide education via that platform. And one thing that we've done at Atrium is we have gone out and contacted primary care providers specifically to encourage them to take care of our patients and partner with them to let them know that our providers are going to look after the sickle cell piece. We got that covered. But they're, sickle cell patients have everything that we all have. And so we partner with those physicians to take care of their healthcare needs in that way.
And this talks about the telemedicine, the echo. Okay. And this talks about this reluctance on the part of the providers to prescribe the medication. While physicians concerned about it being carcinogenic, I guess I haven't heard of any physicians being concerned about it, but they probably are.
My experience is that physicians are under-prescribing hydroxyurea when they have this concern. Again, that once every 3-day thing, the way you treat cancer. I have had patients come to me and call their physicians and they say, well, I got them on hydroxyurea. What they really are saying is, I didn't read the guidelines to see how they prescribe. I used the medication as it was meant to be used in cancer.
Gotcha.
So, is that fear, ignorance? What is that? It's somewhere in there.
Yeah. I think doubts of its effectiveness is actually something that we see in providers. And I've seen this in residents who will see that it's on their med list. So if it's on their med list, then they're taking it, and because they're in the ED, it must not be working. And this is where you have to really just dig, not that much deeper, but just a little deeper, to figure out, well, was it actually filled? And just because it was filled, are they actually taking it? I always start out my conversation with about hydroxyurea to tell the patients, you don't have to tell me you're taking this medication if you're not. Just tell me you're not. Because if you tell me you're not, then guess what I'm going to want to do? I'm going to want to jack up the dose. So you might as well just tell me that you're not taking it so that we just know that it's not a factor in the severity of your disease. And I think that we have run into some problems where we have one particular patient that I can think of wasn't taking it. They were filling it. I don't know what they're doing with it, but maybe somebody needs to drink that water.
They can actually tell you what they're doing.
What are they doing with it?
Somebody fess up.
They have backs of it.
Thank you very much.
They have backs of it.
Thank you very much.
Yeah.
Stop piling it. I don't know what for.
Just in case one day, that's what my son tells me, one day I might decide.
Yeah. So this guy hadn't been taking it. He's been getting it filled, was saying he's taking it, and was taking, enough of it that the MCV was going up a little bit. So I was kind of half believing him. Then he got sick. And then we looked at him and said, you need to take your hydroxyurea. And then he said, okay. He started taking the dose we had him on. Well, it's a little bit too much. White cells. So then we see him back in clinic and I'm like, oh yeah, now you're taking your hydroxyurea. Yeah, I know, and you're taking too much of it. So, and then I'm saying, so tell me, were you really taking it all those times? No, I wasn't. But now I am. Yes, I know you are.
Yeah, we don't need you to please us.
Yeah.
We need you to level with us, because this is a potentially dangerous drug if it's overused.
Yeah.
And if you're not taking it the correct way, and we assume you're taking it the correct way, and then we go up on the dose, and then one day you get religion and start taking that new dose.
All right, let's see if I can go through some of these. Dr. Smith, do you want to talk about ship?
Yeah. Shirley, come on up. It's our time. You are not being put on the spot. This is our baby. So I'll tell you that we did a randomized control trial to try to get people to take hydroxyurea all over the state of Virginia. We even got ECU involved. They're here. And I will tell you it's hard without giving you too much information. It's hard. So Shirley, what did we do?
So we tried to do two different things over a 5-year period. The first thing we did was try to go out in the community around the state using our patient navigators to find people with sickle cell disease to try to get them into specialty care. We realized that there's about probably a third of the patients in Virginia who don't seek any type of specialty care. And ironically, and Stephanie, who was part of that trial, who, raise your hand, Stephanie, so they know, we would find patients who knew patients who weren't in specialty care, and we still could not get the patients to get their friends into specialty care. So we did a lot of the norm, and I'm going to tell you, if you're ever looking to do anything as far as recruitment, especially for the sickle cell population, don't do the normal things. Don't do the health fairs. They did not work.
Listen to her.
I will have to say, in a very disappointing manner, we went to many of the African American communities, barber shops, beauty shops, churches, homeless shelters, drugstores. We went everywhere. And unfortunately, we could not even get the congregation's health education programs to follow up with us to get patients into specialty care. One time, a former navigator and I went to a church, and in the back room, they were doing HIV screening, and somebody was asking about that earlier, and yet we could not get anybody to talk about sickle cell disease. And we're standing in the 90-degree heat, sweat dropping off of us, and we couldn't get one person to commit to somebody coming in. So how we found most of our patients was through our emergency department. And when the patients were coming into VCU, and I can only speak for the VCU center because other centers were a little bit different how they were set up in Tidewater area, we would get their names and we would find that they were not in specialty care, and we would call them. And we offered them an opportunity to come in for treatment, and we were able to enroll patients in the study at our site more successfully doing that. So after about 2.5 years of what we call the phase 1 of the study, we then moved into phase 2. And this was more along the lines of patients who are already in specialty care, whether they came in through phase 1 or whether they were existing patients. Our sickle cell pediatric program, ages 15 and up, participated. Of course, our adult program. We then also worked with the EVMS program, which really it did not go well. The CHKD program for kids 15 years of up, eventually Dr. Yang's group out in Nova, and we then went into East Carolina University and worked with them. And the job of that particular phase of the program was to ask patients to enroll in a study and to randomize them into either a patient navigator group or a control group. And they had to have genotypes of S beta or S beta 0 and SS disease. So patients who had SC or S beta plus were not eligible. And we did enroll about 225 patients, very challenging, into this program. And for a year, those that were followed, or those that were enrolled in the Navigator program were followed for a year. The navigators contacted them weekly. They did community visits, preferably home visits, but sometimes that wasn't something that a patient wanted to do, so they would meet them elsewhere. And they worked into trying to have them become more compliant in taking their hydroxyurea. I don't think I could tell you this part yet, but there was a barrier to what we realized after we did this, and someday you'll hear about that in a paper. But the one mistake that we felt we did make was blinding the navigators to the clinical providers. So in a normal world of what you're going to hear for the rest of the day today, in the next couple days, about community health workers, health navigators, and the 60 other terms that are out there, is that the relationship between them and their clinical providers was key. And our biostatistician felt that that was really going to skew the data. So here we have navigators who were dealing with medical issues with the patients and really could not talk to the doctors. We tried to have them go through like the supervisor in turn would try to speak with the doctor. Sometimes it worked, sometimes it didn't. But we really felt maybe our outcomes to that trial would have been better. What I will say is this, that particular trial led us to be able to go to our healthcare administration, and now we were able to fund the sickle cell medical home. So even though there was some frustrations about the trial, I mean, it was a demonstration project. That's what you do. You make mistakes, you figure out what they are, and we learned a lot of mistakes, and you're going to hear probably on Thursday more about what those mistakes were as far as hiring barriers and things along those lines. But what we did realize is the importance of people stepping out of the place that they work, going to where the patients were, meeting them on their terms was what really helped patients. So even though the adherence factor we can't really chat about, what we were able to find is that many of these patients' psychosocial issues were also being addressed by the navigators. And that really helped us come into play with how we wanted to move forward with the work that we were doing. So I don't know if there's anything else you want to add, Dr. Smith?
Well said.
Is this where we do the questions?
Yep.
All right. So, choose the best answer. Hydroxyurea can A, decrease white blood cell count,
There's no mention.
B,
Oh, there's no mention.
increase total hemoglobin and red cell count, C, increase fetal or baby hemoglobin, or D, all of the above? Yeah. All right, and this is a picture of the hydroxyurea doing its thing. I want to quickly mention other therapies. So, I told you that hydroxyurea was the first FDA-approved medication. There is now a second FDA-approved medication. It's called L-glutamine. L-glutamine is a substance that we all have. And the way I've gotten to explain its mechanism, so L-glutamine is important in the body's ability to remove free radicals. Free radicals are molecules that are left over when there is significant inflammation. It could be from infection, could be from a crisis. And L-glutamine is one of these chemicals, molecules that helps that reaction occur. A visual I like to give my patients is, imagine your blood vessel being a highway, and you have a crisis. The crisis is a pileup 10 miles down the road. Well, here you are now a red cell 10 miles away, trying to get to where you're going. There's a pileup. Well, what's going to happen is you're going to get stuck in that pileup. You might actually be part of the pileup. And then the crisis and the sickling just spreads, just like a pileup. Well, the body has a mechanism that when there's a pileup, from infection, from a crisis, it's the cleaning crew. So they come in and they try to clean up everything to get the road clear so that the cars coming down the road have a clear path. That's what L-glutamine is part of the cleanup crew. And so this drug is basically saying, how can we enhance the cleanup crew? Because we know that when that sickle cell crisis happens 10 miles down the road, if it's still there, it's just going to spread like a big pileup all the way along the blood vessel. So a company said, okay, we're going to study this substance that you can buy at GNC right now. We're going to go study it. So you can imagine, why would you do that when I can go down the street? We're going to go study this to see what is the right dose, if there is such a thing, that can have an impact in sickle cell disease, that can be disease modifying. Now, nobody was probably thinking this is a slam dunk drug. No. But it is nice to see somebody say, we know that this is another potential treatment. We have no illusions that this is going to change the face of sickle cell disease, but it is yet another thing that we can offer our patients. And we're going to study this in a rigid, methodical, scientific way to figure out, does it work? And if it does work, what dose? And so it was successful, and it got approved in 2017. Comes in a powder form that you have to mix in water, because you have to take the amounts are, so if one capsule of hydroxyurea is 500 milligrams, and let's say you have to take 4 of those, so that's 2,000 milligrams, 2 grams. For L-glutamine, you have to take 15 grams twice a day for somebody my size. Well, if that came in a pill form, I'm not taking that much pills. So it's in a powder form that you mix in water. We have some patients on the medication. And again, is it changing the face of sickle cell disease treatment? Maybe not. But look at every other chronic disease. There's a long, nice menu that patients and providers can pick from. That's what we want, and that's what we need for sickle cell disease. Then there is, I'm going to butcher the crizanlizumab. Oh, I got it right. Oh, perfect. Now, remember I said that sickle cell disease isn't just a plumbing thing. Understanding that sickle cell disease and sickle cell crisis is when red cells bind to white cells, and the white cells stick to the surface of the wall, and all that just kind of slows down. So it's not just the car crash, but it's like everybody's pumping the brakes, slowing down. Well, scientists know what are the two things called a ligand, it's like a protein, that one cell uses to stick to the other. And so they created a drug, which is a molecule that will go there, and if I'm the white cell with my little ligand, and I'm about to stick to the wall of the blood vessel or to a red cell, then this molecule can literally bind on that ligand, keeping me from sticking to the red cell. So it stops this stickiness of these cells in the blood vessel. So they found this out, and they said, okay, let's create this drug. It's an infusion. The molecule, the ligand is called the P-selectin. That's the little ligand that attaches the two cells. And this medication is just an antibody that sticks to that P-selectin. And they did a study, and it's an infusion, and yes, it does reduce and prevent sickle cell crisis. So the idea is that this will be an infusion that is given routinely, kind of like how we have infusions for rheumatoid arthritis. You go in, you get your Remicade or whatever it is. This month, you come back, you get it again. Doesn't mean you don't have rheumatoid arthritis, but it might mean that your joints are a whole lot better. That's our hope. It doesn't mean you don't have sickle cell disease, but your crisis is a lot less. This is hopefully going to be approved soon. Voxelotor is another drug made by GBT. So what this drug does is remember I said that hemoglobin have these two chairs, and the hemoglobin has oxygen. And at some point, the oxygen gets popped off. And when it pops off, those hemoglobins, those four chairs, they don't stay as four chairs, they bunch together. So if this is the room and we're one big red cell, and all the oxygen leaves this room, the chairs are going to want to bunch up. But what if I had a way of not letting all of the oxygen leave the chairs? So maybe this bunch of hemoglobin held on to its oxygen, and this other bunch, they gave off their oxygen. So that's good because it needs to give off its oxygen, because then that's a bad thing. So the red cell is still giving off its oxygen, but some of the hemoglobin is holding on to this oxygen. And if enough of the hemoglobin is holding on to its oxygen in this one red cell, then maybe these other ones are going to form a big bundle, but we're still going to be hanging out the way we're supposed to be hanging out. Kind of like how hemoglobin F does. And if we're hanging out the way we're supposed to be hanging out, maybe it's going to prevent this big one red cell from boop, becoming sickle. Voxelotor is a drug that will come and bind to these hemoglobins here, which then makes these hemoglobins hold on to the oxygen a little bit harder, a little bit tighter, not giving them up. So in the end, you would have this one red cell that will still give off its oxygen like it's supposed to, but be selfish in one area and hold on to some of it so that it doesn't cause the whole room to create a polymer. That's what the drug is. It's a pill form, and what they found is that it increases hemoglobin in the patients that are taking it. And fortunately, what they've found in the initial studies is that with the increase in hemoglobin, we talked about viscosity, we talked about kind of almost backward thinking. The higher the hemoglobin, sometimes it may cause problems. Where in this study, it did not cause problems. It did not increase the viscosity or the thickness of the blood system because it raised the hemoglobin. So that's good. The other thing that it did, there's evidence that it decreased the amount of hemolysis. Because every time the red cells bends, your body destroys it. And we can do blood tests to measure that destruction and get a sense of, is that being destroyed? We can do that with a test called an indirect bilirubin. So what we noticed is that the bilirubin decreased. There was less hemolysis, less breaking up of the red cells, which is a good thing. And I think this drug is fast-tracked for FDA approval. That just came out February, yeah. Next one is sanguinate. So sanguinate is kind of similar idea, except that you're using a bovine, a cow hemoglobin. And I'm glad they picked a cow and not a pig, because that would just ruin half of the world's market for this drug. So here is this modified cow hemoglobin that is, help me out here, Dr. Smith.
Just lasts longer.
It lasts longer, and it holds on to oxygen, and you can infuse it. Any update, Dr. Smith, on studies?
I know nothing.
Yeah.
I don't know. That's a black box.
Yeah. We studied this one at VCU. We tried to study this one. It was hard to get patients because it needed to be an infusion during a crisis. The other one, the other infusion drug was just a standard infusion. You didn't have to be in crisis. So imagine trying to run a trial where you say, when you're in a crisis, sign this consent form. Yeah. This is what I talk about exchange transfusion briefly. So we all know simple transfusion. You're anemic, you get blood. When you give somebody whole blood, that comes with the red cells, it comes with the plasma, it comes with a whole bunch of proteins. And after a while, you get antibodies being formed, you increase the thickness, you give a whole bunch of iron, and it's problematic to just give a simple transfusion over and over for years and years. So there's exchange transfusion. So here's what it looks like. It kind of looks like a dialysis machine. And what it does is it takes donor blood. So you're getting donor blood, but what the machine does, it spins the blood. So it separates just the red cells. So that's really what you want. You want the red cells which has the hemoglobin that does not have sickle hemoglobin. So you want just the red cells, and you do away with all the other plasma and everything else. And so when you transfuse the donor blood, what you do is you are giving the patient, let's say, 5 units of this kind of concentrated red cell donor blood, but you're also removing the same amount from the body. Why do we do this? Well, the idea, this isn't to treat anemia. So if I have a big crisis and my hemoglobin is at 3, and you say, my goodness, we need to get you back up to 5, you're not going to give me exchange transfusion. You're just going to give me blood. But let's say if I have a stroke or I have acute chest syndrome, you want to try to rapidly decrease the percentage of hemoglobin S in my body. You want to decrease it. Now, you can decrease it by giving me a whole bunch of blood, because obviously you're going to be giving me blood that's not from a sickle cell donor. But an ideal way is to remove a whole bunch of blood from me that has hemoglobin S, and then give me a whole bunch of red cells that has hemoglobin A. So you're doing this rapid exchange, And we do this when, and the way, so let's say if I came in with a stroke, you would get a hemoglobin electrophoresis. It would tell you, what is my hemoglobin S percent today? So let's say it comes back, I'm at 95, is all S, and the rest of it is the normal A. Then you can say, okay, studies have shown that the treatment is to get that S percent down to 30%. Well, what's going to get you from 98 or 95 all the way down to 30%? You would have to give me a whole bunch of blood to achieve that. And oh, by the way, you're going to put me in heart failure because you've just given me someone else's whole bucket of their blood. Ain't going to work. Well, you can remove a chunk of my hemoglobin S and then put hemoglobin A and have a rapid improvement in my hemoglobin S percent, getting it rapidly from 95 or 90 whoop, down to 30%. That's the treatment for an acute stroke in a sickle cell crisis. And then, in a perfect world, patients will then remain on exchange transfusion because that's the most efficacious thing to prevent a second stroke. To get exchange transfusion, you have to get a port. A port is a direct access that goes in eventually into your heart, and they're able to tuck it right underneath your skin, and they usually have it's one port as far as what you see under the skin, but it kind of has two little access points where they can remove blood from one, give blood from the other. But it is a procedure that has to be done. It's done all the time for people getting chemotherapy, so it's not a big procedure. But you then have this foreign body in you, and you have to protect it with your life. Because if it gets infected, and they often do, the infection is directly in your bloodstream, and you go from not having an infection to now having sepsis. Yes?
For the ports, is it because some people just don't feel correctly, like over it, or like what's causing so many infections with ports?
Somebody can tell me if they know. I think part of it is how it is accessed by the healthcare professionals. The nurses, you have to be trained if you're a nurse to do it, so not any nurse can do it. So I think part of that is that. And I think the reality is, anytime you have a foreign object in you, you're at risk of infection. So, a hip joint, a heart valve, you don't have to do it, do anything to it, but now you have a foreign object that is consistently being accessed every single time. So even with perfect hygiene, the risk of infection is just going up. So it's just the nature of it.
That's what it being access to.
Yeah.
So my husband gets a red blood exchange every 4 weeks, but he doesn't have a port.
Yeah, so some people just get poked. That's hardcore.
He never gets sick.
Yeah, that's hardcore. Yeah.
Can I ask for patients who get them every 4 days, how do you determine how often someone should get it?
I don't do the determining, the transfusion medicine folks do it. It's based on their weight, and obviously the smaller you are, the quicker it is to get you down to 30% if that's the goal. So if you are 5, then you just remove, 2 units and put in 2 units and you're done. If you're Dr. Smith, so it's size. But they have a very clear way of how to do it. Yeah.
So to my knowledge, most in the medical community are looking forward to voxelotor and its release and how, the mechanism for how it works. But there's also a lot of conversation about an ICER review that's coming up that's extremely concerning. How is there any position that the medical community is taking, or are they collaborating on any level to prepare the community for this? Because it can be a make or break to the success of this treatment.
I guess do you want to tackle that, Dr. Smith?
Yeah.
Okay.
I don't think this is confidential information I'm disclosing. ICER invites commentary, and many experts around the country are involved in making comments. And so it's not lost on the sickle cell community that we need to comment as disease experts on the way ICER will operate for this particular drug, on the unmet medical need, on the sensitivity to pricing, and the need to not be sterile, which is, I think that's your underlying fear, is that ICER will be sterile. And I'm not going to explain ICER to everybody. Your sophistication level is way up there. So we're not going to let them get away with that. Does that satisfy your curiosity? Yeah, I will. Yeah. Sidebar. Now you're the expert, because you said ICER, so you even know what it stands for, and they're going to come talk to you.
Hey, don't feel bad. I'm just sitting here pretending like I know what they're talking about. Any other questions?
Is the wasted blood discarded, or is it given to?
No, it's discarded. Yeah. Yeah. All right. It's your turn, Dr. Smith. All right. I will be seeing everybody tomorrow. I have to step out and get my 5-year-old kid from school. So thank you very much.
Okay, so we're cruising around third base on our way home. And I'm going to talk to you about cures for sickle cell disease. I don't have a Mentimeter for this. I don't have a slide for this. But I do. I'm just, I don't have a slide for what I'm about to show you, the question I'm about to ask. Okay. You get to vote. A, if you think 20 people worldwide have been cured of sickle cell disease. B, if you think 200 people have been cured of sickle cell disease worldwide. C, if it's more like 500 people have been cured. And D, if you think it's more like 2,000 people have been cured. All right, so it's 20, 200, 500, 2,000. Okay, let's see the hands who vote 20. 20? Okay. Okay, 200. All right, 500. That doesn't leave too many people for the last option. 2,000. A few people. So the answer is 2,000. Yeah. So, and if you cheated and looked in your book, shame on you. So that's the answer, and I think what that illustrates That should have been very instructive to everybody. So that illustrates that even the experts, and you guys are already experts, even the experts are not completely well versed on what's out there. And so I'm here to talk about that. Two major types of bone marrow transplantation to cure sickle cell disease have been utilized. Now, the first one is actually the second on the list here, and that's the full antigen match. And without going into all the science, just know that there's 4 antigens, and if you match on all 4 of them, those tissue antigens, then you have a very good chance of holding on to your transplant once you get it. So that makes you a very, very safe risk of holding on to your transplant and having it work. If you don't have 4 antigens match with your donor, less of a chance of holding on, okay? As you might imagine, that means family members have a better chance of being a match for you, and that is why Be the Match runs around trying to get everybody to get their family members to give samples to see if they are a match for them in case they need an organ. And the organ in this case is bone marrow for sickle cell disease. Now let's talk about haploidentical. That's just a fancy way of saying 2 instead of 4 out of the possible 4 antigens are matching. Risky because you might not hold on, right? But there's way more of a chance of you finding somebody with at least 2 antigens to match you, and so your donor pool is much larger. This is catching on, and people are willing to try that more and more. And when you're doing these transplants, the goal is not to give too much chemotherapy as to poison you, but to give enough to poison your bone marrow enough so that it will accept somebody else's bone marrow. Make sense? And then there's that dreaded after effect called graft versus host disease. And that happens when the marrow that you received from somebody else attacks your immune system. So it actually has a life of its own and says, I don't like living here, and I'm going to destroy this house. And you have to take medicine for that. But as you can see, there have been looser and looser criteria for enrollment in bone marrow transplant studies. Everybody who gets a bone marrow transplant is on a study, by definition. There's nobody out there renegade doing bone marrow transplants. They're all registered. We're following people. That's how we know that 2,000 people worldwide have been transplanted. At this point, and Dr. Sisler, you can chime in, some would say that transplant is considered the standard of care now for a child with sickle cell disease who is severely ill. I don't know your opinion about that.
If they have a match sibling.
4 out of 4. That's a 4 out of 4.
Yeah. So if you have a matched sibling donor, it is a standard of care to take patients with sickle cell to transplant, even if they are not severely ill.
Do you hear that? Even if they're not severely ill, some say prevention is the key. Transplant them now. There's a 95% probability of success, correct? Something like that? Okay. Go.
And it should be a whole sibling.
Total sibling. But the donor can have sickle cell traits. That's fine.
But
Yeah,
the
that's
sibling
people don't
not
know
a
that
parent.
part. Yeah.
The sibling, not a parent, right?
Correct. The parent can be a haploidentical.
Yeah. So you can see how sophisticated this stuff is. I'm trying to just simplify it. 4, that's the full antigen. 2 is the haplo. You can remember that. 4, 2. Those are the 2 types. Okay. And the balancing act is the other thing I want you to remember. Enough chemo to poison you so that you don't reject somebody, but not too much to kill you, and enough rejection drugs to keep their bone marrow that's transplanted into you from killing you. Those are the things that we're screwing around with, well, that's not a right word, experimenting with in our trials, okay? But we're getting better and better and better. And interestingly, you do not have to have 100% hemoglobin A to get benefit. So you can actually have less than 100% hemoglobin A and get benefit. Some say as little as 40% hemoglobin A is enough to give you benefit. So it doesn't have to be a full take, if you will. Just get enough of that bone marrow in you from somebody else that it starts to interfere with the chairs. Okay? Same idea, and it works. The STRIDE-2 study is an adult-only protocol that is doing what's called biological randomization. What does that mean? That means that we're not going to accept you into the study until you say you want a transplant. And we're not going to go looking for a match until you get accepted in the study. And what that allows us to do is figure out, A, the chances of you getting a match. We have some idea of that, but we have not studied that well. And B, a natural group that says they wanted a transplant but did not get one, and how well they do. So something like 3 or 4 people out of 5 will be in the group that didn't match and will not get a transplant, but we'll still follow them over time. That's our control group. And then the other patients will be the ones that got a match, got a transplant. We need people to step up and do this study. We really need people to step up and do this study. One of the reasons why is because now the NIH is really behind the idea of extending this technology to as many people as can get it. Yes, ma'am.
For the STRIDE study, is it only for those who are indigent or?
It is nationwide. Nationwide. In fact, it's headquartered in Atlanta, but it is nationwide. Maybe even Canada. Yes?
What does your, I don't say the word state, does your disease process have to be in to be accepted or enrolled in that?
It's pretty much the same as the hydroxyurea that we just saw. So you remember all the things we talked about? Any of those criteria, and believe me, as they get more and more desperate to get people into this study, the enrollment criteria are getting looser and looser. So I would simply say, come see us, regardless of how sick you are, if you want to be in the study. I don't care if you've been on hydroxyurea or not. Doesn't matter. Yes?
I would say that it's pretty nuanced because a lot of these patients are transplanted on clinical trials. So for some trials, they have very specific enrollment criteria. You have to have X, Y, or Z. But it would take a little bit of, there have been patients who have been transplanted off study. So there are patients, if they have a good donor who the family's really motivated, the patient's really motivated.
Privately funded.
And the transplanter is interested, feels like it's a safe and viable option for them.
Yeah.
Then there are patients, because you're right, you don't want patients to be at a disadvantage because they have really worked hard.
How many would you say have had that happen? No protocol, just got transplanted.
We've done a few here.
Ooh, there you go. So I take it all back.
So when you said nobody's going rogue, I was sitting here going,
I take it all back. You have to enroll them in a registry, though, don't you? No?
They are enrolled in a transplant registry, which data is not readily
Ooh.
cell
Ooh.
So it's a little bit of a nuance.
So is it more like 2,500? Not 2,000?
So what happened to it when they used to say you had to be 50
Yeah, I hear you. Go ahead.
Yeah, 50% chance
Yeah,
before you could,
right.
I mean, you know.
People were just trying not to get people into this potentially risky therapy who weren't ill enough, whatever that means, to need it. Yeah. But as we've gotten better at doing it, guess what? More and more people can benefit, so you don't have to be quite as ill. Oops, I went backwards. How did I do that? Now, the other thing I want to talk about is gene therapy. I am not going to spend a lot of time on this, but what I want you to hear is it's happening. That is like really the thing. So everything you see on that slide, I am not going to go over. But in case you want to read about it, there it is. But gene therapy is happening. 3 ways to do gene therapy. Replace the mutated gene, inactivate or knock out the mutated gene. The first is called gene editing, where you replace the mutated gene. Knockout is what it sounds like. You inactivate the mutated gene. And the third is introduce a new gene and leave everything else as it was, but you got a new gene in. 3 ways to do it. Yes?
I know you say one that's done a lot of times, but this is the one with the HIV.
Lentivirus.
Well, I'm sorry.
It's because if you say HIV, you're implying that you're giving somebody a disease, and that is really not true.
Well, right, this is.
That's not true. So I'd rather say lentivirus because that, number 1, is the absolute truth, and number 2, it is not about AIDS.
Right, so
Yeah.
60 minutes.
The 60-minute thing caused a lot of, we can have a long sidebar about the 60-minute thing. My take-home message is, it's happening. Coming to a theater near you. In fact, coming to VCU. Yeah,
I need to get that in my vocabulary.
yeah.
That's about it.
That's what you say. That's the one where you were actually infusing modified cells, so you're introducing. All right? I think I'm going to stop right there. Do we have a question to go along with this? No, we're out of time. Okay, I think we're about to move now, literally, physically.
So has everybody felt that they have learned anything so far yet today? We want to thank, of course, we have one more spectacular presentation to wrap up our day. But like all endings of our segments today, we're giving away some more prizes. So those of you who have not been able to have your name come up yet, that's why he thought we were moving. Okay, I see. Go ahead. Yay! Next. Really tune that back down. Okay, 2 for 2 so far. Just watch you don't trip over the cord. Is Marie here? Okay. She's not coming either, right? Okay. Alicia is our pediatric social worker. And last but not least for this segment, Marcia? Now, we're gonna do one more wonderful move before we, get to our next break. No more dancing. Well, not today. I can't promise you about tomorrow or the day after. But we thought everybody might want to do something a little bit more relaxing towards the end of the day. Okay.
I don't know if she has sit in here. So we find out.
Well, we hope our person set it up.
Yeah.
No. Oh, you got a link.
Yeah. I was hoping that it opens.
Well, or not. She had linked it. All right, if everybody would stand up, we're hoping this is going to work.
Oh, it says, gotta go talk to your doctor.
Is it going to go automatic?
Okay.
Sure, yeah, it is.
I think this is just the entrance into it. Yeah. Yeah.
Hi, welcome to yogadownload.com. I'm Jackie Cassell-Maru. I'm going to lead you through this very quick stand-up and stretch class. This class is designed for you, for anybody that needs a quick stretch break. You can do this at the office, in your cubicle, really anywhere. You don't need a yoga mat. You can keep your shoes on if you want to. Here with me today is Amber Buger. She's going to be demonstrating the postures with me in case you need a visual. Come to your feet. So stand up. And bring your feet hip-width distance apart. So take a look at them, make sure they're right underneath your hips. And just press all four corners of your feet down into the ground. Firm up your legs, so engage your quads, engage your thighs. Lengthen your spine and lift your chest. Pull your shoulders back. And turn your palms just to face forward. Close your eyes for a moment. Come to the breath. Let's take a quick moment here just to shelve anything that you're doing. Mentally shelve it. Let go of your to-do list and anchor yourself right here in the present moment. Come in your body, come in your skin, and just feel the sensations. Take a breath in together through your nose. Exhale through your mouth. Inhale through your nose. Exhale through your nose. Inhale through your nose. Through the nose again, exhale. Open your eyes. Reach your arms up and over your head. Just stretch up as tall as you possibly can. Reach out of your waist up towards the ceiling. Press your feet down into the floor and reach your arms up as tall as you can. Feel how good it feels to stretch, to lengthen. Now take your right hand and grab a hold of your left wrist. You can turn your left palm to face in front of you. Gently press both of your feet into the mat and lean over to your right side. Don't fall over to the right, but consciously lift out of your waist and lean in that direction. You can pull on your left wrist a little bit too. Now from here, bend both of your elbows and take your right hand, grab a hold of your left elbow. Your left hand can grab a hold of your right elbow. Pull your chin from your chest and just lean a little bit over to your right. If it feels good, you can look up, turning your head a little bit. And release, return to center. Reach your arms up, give it a big stretch. Then we'll do the other side. Left hand to right wrist first, lift up, stay grounded in your feet, and then lean over to the left. So by grounded, I just mean pressing all four corners of your feet into the mat. Pull your chin from your chest, lean a little bit more to the left. Now bend your elbows, grab a hold of each opposite elbow and just lean a little bit more. You can pull on your right elbow with your left hand to get a deeper stretch through your shoulder and side body. Look up if that feels good on your neck. And then release. Reach your arms up one more time. Interlace your fingers. Flip your palms up to face the ceiling. Stretch out your hands. Maybe you've been typing all day, texting, writing. Press up and stretch. Stretch out all the fascia in your hands. And then release. Bring your arms by your side. You can let the blood flow back into your hands, into your arms. From here, interlace your hands behind your back. So if you're able to, you'll bring your palms to touch behind you. If not, you can just grab a hold of your wrists. Press down through your feet, engage your legs, squeeze your shoulder blades a bit together behind you. Lift your chin a little bit from your chest, and just start to back bend a little bit. Just open your chest up towards the ceiling. If it feels good, if you're really flexible, you can back bend a lot here, but you don't have to. Just get the opening through your chest. You might have been rounded over a computer all day or driving. Whatever you're doing, I have a feeling this is a good counter stretch for it. Look up and breathe. And release. Come back to center, back to a neutral neck. Keep your hands behind your back. Take your right hand and grab a hold of your left wrist. From here, hold onto your wrist and pull it down a little bit. Now, just look directly in front of you, but bring your right ear towards your right shoulder. As you bring your right ear towards your right shoulder, pull down on your left wrist a little bit to get a deep stretch through the side of your neck. Find a sweet spot and just hold and breathe there. And release to center. Take the other side. Take your left hand to your right wrist, press down through your feet, and then pull your right wrist down. Chin is at neutral, and bring your left ear now towards your left shoulder. You can get a deeper stretch if you pull down on your right wrist. You can kind of lift your chin up a little bit, find that sweet spot, and then just hold. Just let the tension in your body dissolve. It will over time and with a lot of practice. And release. Slowly come back up to center. From where you are, bring your hands together at your heart, or you can bring them onto your waist. Bend your knees and sit your hips back. Figure 4, we call this. Take your right ankle on top of your left.
Okay. All right, we're done.
Right there.
All right, we're going to reconvene in about 10 minutes so that we can wrap up our first day. There's another break out there for you, and then we'll reconvene in 10 minutes. Yeah, we just went a little too far there. You know, I still can't grab my arms like